Good morning. Welcome to PrevMed YouTube live show. My name is James West. As you may know, many of you are listeners and watch us in the past and know that I sometimes co-host with Dr. Ford Brewer for the PrevMed show. I'm doing that today, but this is not Dr. Ford Brewer. For those who have been on before and know that this is Dr. Ryan Rayner. Dr. Rayner is one of the medical physicians that work with us in Jubilee Primary Care down in Baldwin County, Alabama. He's joined us today for our program. We had a little technical difficulties. He was going to go from a different laptop and we could not get that working. So we're getting to sit and do this show in close proximity. I don't know that our screens can hold that much good looks in one spot, but and my chair is not, for those that want to comment and say, scoop my chair up, this is just, he's a very tall guy and I am not. So, but we appreciate everyone for joining in. We hope to have a good show today. Our topic is going to be atrial fibrillation. Dr. Rayner will join us for a short time as we discuss that. And then I'm going to turn him loose. We actually have patients. We had traffic issues today. And so our patients had to adjust their schedule somewhat, and that's going to put us in a little time crunch. So Dr. Rayner will join us for a little conversation about atrial fibrillation, and then he will jump in to see patients. And then I'm going to give some updates on the progress we're having, Dr. Brewer and I, in our project in Baldwin County, Mobile, Alabama, with fee-for-value healthcare. So thank you for joining. Atrial fibrillation will be the conversation, and Dr. Rayner will join us. But before we do, we want to remind you, you can go back into all of our videos on the YouTube live channel and begin to look at some of those previous topics, such as unlocking the secrets of sleep, which was last week, and preventing diabetes and heart disease. And then, of course, prevention myths such as calcium scores and how they're impacted with stress tests and so forth. So all of those are available. Low carb diet, we've done those as well, and the benefits that has. So if you would be so kind to go look at some of those, and then continuing at that, we also have a website that you can go to, the PrevMed website, and check out things such as all of our programs, our webinars. We have a regular webinar that takes place monthly on various topics that you can sign up and join. On our website, you can also see, for instance, the books that we have available. More recently, Dr. Brewer with Todd wrote a book on the prevention myths of heart attack and stroke relative to stress test. And then you've got the courses that you can sign up for. As you can see, our slides are not perfectly in time with me talking. I'm talking a little faster than they may be able to keep up. But you can go look at our website, see the availability of the book, see the opportunity to sign up for the courses, be able to see everything about PrevMed and keep up with it. So we would love for you to join us for that, as well as if you're interested in being a patient. Dr. Brewer has the concierge service if you're looking for some concierge telehealth coverage. And if you live in the lower Alabama area, Baldwin County, Alabama, or Mobile, Alabama, or have family members down here, you can introduce us to our website. You introduce those people or yourselves to jubilee.health. Jubilee is JUBILEE.health is our website. You can go there and sign up and just be a Medicare age or Medicare eligible patient to the clinic and see Dr. Rayner or Dr. Brewer or Dr. Coleman, some of the other providers. We'll have 4 clinics open by January 1st. between Mobile and Baldwin County, Alabama, in places like Foley, Spanish Fort, Fairhope, and then Mobile. So anybody that has family down here, they can get a lot of the care that we talk about on this show with a hands-on effect, work with these fine doctors that we have. So hidden atrial fibrillation, we call it hidden for a reason. I'm going to turn it over to Dr. Rayner. I'll go back and forth with a few questions. But Dr. Rayner, would you be so kind to introduce us to this topic of hidden atrial fibrillation? What is it? Why should we be concerned about it, and so forth?
So I'll start out by telling you what atrial fibrillation itself is, and I can tell by some of the comments I see along the side already that most of you actually know what it is already, and some of you have been treated for it already, and some of your brothers have been treated for it, or things like that. And I've actually been treated for it myself in the past. I've actually had it 7 or 8 years ago, and it was an odd situation that I had it, but that's a story for another day, I think. But atrial fibrillation itself is a rhythm of the heart that is when the heart is out of rhythm. And the fibrillation means basically the atrium, which is the top chambers of the heart, the smaller chambers of the heart, are out of rhythm and they're fibrillating, which means they're just going like this and they're not pumping normally like the heart would. So the reason that happens is because every time your heart beats, your heart has an electrical conduction that starts in the atrium and the sinus node up there in the atrium, and it conducts a nice smooth electrical impulse down to the ventricles, and it beats very regularly on most people, and it works just like it's supposed to. But sometimes there's a little electrical impulse there that's out of whack, and it kind of has gets off the track. Basically, it's like a train track that somebody has switched the track, and you're going in a small circle track instead of going straight down the track toward the right direction. So it causes the atrium to fibrillate. And the bad part about that is it can stir up the blood in the atrium or the atrial appendage. And if it stirs up the blood long enough, it can cause a blood clot to form there, a thrombus to form in the atrium. And then the worst part is that it can cause a stroke because that little blood clot will be thrown off and go up the arteries into your brain and cause a stroke. We're talking today about hidden atrial fibrillation. Another word for that is subclinical atrial fibrillation. And what that means is people that don't realize they have it. Some people do realize they have it. When I had it, I felt at the very first beat that I was out of rhythm. I could feel it, but some people can't feel it. And in some people, that means that the first thing they know about having atrial fibrillation is having a stroke. That's terrible. That should be something that we could prevent. And that's why we're talking about it today, to see if there's any way we can prevent it and see if there's any ways to catch that sooner. 130,000 people a year die from atrial fibrillation complications. Just let that settle in. 130,000 people a year. One source said 158,000 people a year die from atrial fibrillation. I don't remember exactly how many people died of COVID last year, but it's twice as many people die of the flu every year. That's a lot of people. And if we could prevent that, that seems to be a good thing to do. But we're going to talk about the hurdles to that today too.
Well, thank you, James. Thank you, Dr. Rayner. And again, we're sitting here next to each other, and we have to force ourselves for our listeners to look at the screen with the questions. So it's bad. We feel your pain. You have to look at us. We have to look at us. It's a struggle. A few of the questions that we have, it's interesting. It's called hidden. So there's obviously a lot of people who have atrial fibrillation, may have even felt the symptoms of atrial fibrillation. There's the hidden part where maybe that could be, there's some symptoms that they discount the symptoms and maybe credit them to something else. For instance, people describe atrial fibrillation feeling like you're having a racing heart. But that's also the way it feels when I have 3 cups of coffee before 10:30 in the morning.
True.
So is it that possible that there are symptoms? What are those symptoms that you may be looking for that you may, no one wants to believe they have some underlying real condition. Some people won't believe everything is, but most of us, if we have a symptom, we may discount it completely. So what are those symptoms and when should we be concerned about them? And then ultimately, what should we do if we're feeling those symptoms?
So this is something that you need to look out for, because atrial fibrillation is the most common arrhythmia that people would have. And as you get older, it's more and more common. People over 85, 10% of people over 85 will have atrial fibrillation. And from 65 to 85, it's anywhere from 1 to 7% of people may have it. So it's definitely something you need to look for, but sometimes it's hard to tell. I don't know if some of you can feel your heart beating. I can feel my heart beating sometimes. Just like James said, if I drink some caffeine or something like that, it seems to beat harder or something like that. Or if you're, some people, if their blood pressure is higher, they can feel their heart beating. But you can also feel your pulse. Like if you feel your pulse and you can feel it beating regularly, you can feel it on your neck, you can feel it beating regularly, and it just beats just regularly like that. If you have atrial fibrillation, you may feel what is called palpitations. Palpitations is basically when it feels like your heart is not beating regularly, when your heart is beating a different way than it normally does. And that may be the first symptom, palpitations. You may also feel lightheaded. You may feel a little dizzy. You may feel a little short of breath. And if you're feeling short of breath and dizzy and you feel your pulse and it's very rapid, you could have one of a few different arrhythmias, but atrial fibrillation would actually be the most common one. So that's something to look out for. If you do feel your pulse and it's rapid, but it's irregular, atrial fibrillation is called an irregularly irregular rhythm. So that's kind of a mouthful, but what that means is some rhythms are irregular in that they're too fast, like say tachycardia is too fast, but it's regular. It comes at 150 beats a minute, but it stays that 150 beats a minute. AFib can go from 70 beats a minute to 150 beats a minute to 130 to 120, all within 1 minute. So it's very irregular and it's bouncing all over the place. So if you feel your pulse and it's bouncing like that, then it definitely is something that you need to have checked out, particularly if you have dizziness or feel short of breath or something like that with it. But again, 20% of people that have a stroke associated with AFib, the first sign of their AFib, they felt nothing before that. The first sign they had was a stroke. So it's not something that everybody can feel, but if you do feel it, it's something that needs to be checked out for sure.
Well, that's so what you're saying is it can be persistent. Some people have persistent AFib, but it can also not be persistent. It can come and go. And so one of the questions that are already listed on the screen, it's a great time to maybe ask that question is, Apple and other companies make devices that, because if I feel that arrhythmia, by the time I call and make an appointment and get in to see the doctor, I could be out of that arrhythmia. So what would you look for? Would you order an EKG? And what do you think of these devices that Apple and others make that allow you maybe in real time to test whether or not you're out of rhythm?
Yeah, so my son was having some palpitations when he was in college, and we bought a device that went with his Apple Watch. He didn't have the newest Apple Watch, so he bought a device where he could just put the 2 thumbs on it and he could put those on the little pads and it transmitted to his watch. And he would have symptoms that he thought were related to that, and he would send me an EKG and it would always be normal. But they can pretty accurately show AFib. And I was on an airplane, not too long ago, and somebody was having some heart problems, and it was the old, is there a doctor in the plane? And I was like, here I am. And so I went back there, and a guy had an Apple Watch, and he stuck it on the person that was having a problem, and it showed their heart rhythm, and it's pretty accurate. They were not an AFib, but I have definitely seen people in AFib that had an Apple Watch, and it definitely showed the AFib. The problem with using that for screening is that a lot of people that have Apple Watches are not in the group that AFib is prevalent. I mean, how many over 85-year-old people do you know that have an Apple Watch? So they do work, but most people that have an Apple Watch are younger. Like, I don't even have one. My son has one. He's 21, and my daughter has one. She's 17. They're not in the group that has AFib, so they're gonna be using it, and there's gonna be some false positives because they're not in a high probability group.
But there are some, I do hear that there are some people at younger age that can go into AFib. And is it possible that exercise, I hear people that do extreme exercise sometimes exercise themselves into AFib or arrhythmias. Is that accurate?
So
probably not our audience doing a lot of that, but
not,
I think
not the people here on this screen. So that is possible. The way you exercise yourself into AFib or another arrhythmia is to get abnormality in your potassium or your sodium or your calcium by being dehydrated and being exercising too long without drinking enough water and things like that. So that would be fairly rare. The main risk factors are risk factors like everything else that we probably talk about on this show, and that's diabetes and obesity, hypertension, smoking, heart disease. Those are the main risk factors for AFib. So if you already have hypertension, you already have diabetes, and then you start feeling that palpitation, definitely you can check it on the watch, or you can check it on one of the other devices. And if it says AFib, you need to go have a 12-lead EKG done, and you need to get it checked out. If you do have AFib, you need a physical exam by a doctor to listen to your heart. They can hear the rhythm on your heart. You need an EKG. You need an echocardiogram to see if there's any structural problem with your heart or with one of the valves that's causing the AFib. You need thyroid tests done because hyperthyroidism is another risk for atrial fibrillation. It's almost like funneling caffeine all the time if you have hyperthyroidism, and it can definitely give you AFib.
Not that funneling caffeine all the time is a bad thing.
That actually is probably what caused my AFib. But you also need to be checked for renal and hepatic function, and those are other things that can cause AFib. So, all right.
No,
next
perfect, fantastic. Well, we're getting a lot of comments, and I know I need to turn you loose, but some of those you've mentioned, such as magnesium, potassium deficiencies, which a lot of times is directly related to just being dehydrated. Just
right.
That's one of the more common things, particularly in the summer and the weather, and so one thing leads to the others. So tell me a little bit about what, if you are concerned, you would just schedule a time with your provider, ask for an EKG. What other screenings may there be that, because I know you want to catch it when it's happening, but what would you recommend someone do if they're concerned about it?
Yeah, I would definitely recommend going on in and having an EKG done. And sometimes atrial fibrillation is an emergency. So sometimes you need to go into the emergency department. And the time when it's an emergency is if you're having these palpitations or you're having that feeling that your heartbeat is irregular and your heart rate is above 110. So your heart rate is tachycardic, 120, 150, 170, and you don't feel stable. You feel dizzy, you try to stand up, you can't really walk, you feel out of sorts, and you feel maybe you even have chest pain. You may feel confusion, anything like that. So that means it's an emergency. You should actually go to the emergency department. If you have it and it lasts 5 minutes and you didn't really feel that bad, then you might call in and get an appointment in a day or two with a doctor. But it is something that needs to be taken care of in a day or two. I see a lot of questions about treatment, and I can hit on that really quickly. Please, I'm going to have to slide out here in a second, but there are definitely some treatments. The main standby treatment is rate control. If you have a heart rate above 110, you need rate control with atrial fibrillation, and that's done with beta blocker type medications like metoprolol or something like that, or a calcium channel blocker like diltiazem or the like. Besides rate control, you also need your blood to be thinned. You need something that's a blood thinner to help that thrombus not form and help you not have the stroke. There's older medicines like Coumadin and aspirin. Coumadin was proven to be superior to aspirin in prevention of stroke, but it had some bleeding problems. So they came up with some more direct anticoagulants such as Eliquis and Xarelto and Pradaxa. Those medications are as good or better than Coumadin in preventing stroke, and some of them are better than Coumadin as far as not having bleeding, but you can get major bleeding with any of those. Combining those with aspirin is not a good idea. There's much more chance of bleeding either intracranially or intra-abdominally, and so it's not a good idea to combine those things. I see some people talking about ablation. That is something in the right context that is a good treatment. An electrophysiologist can go into your heart with a catheter, and they can either cryoablate it or they can ablate it with heat, with cautery. For long-standing persistent atrial fibrillation, it's not necessarily the best thing. The best thing probably is just to control rate and to control to thin the blood. There's also other things that have been FDA approved, and there are these little devices that they can put in through surgery, and they can basically close off your atrial appendage, and they either they burn your atrial appendage and scar it together, or they put a little device. It's like a little box that closes off your atrial appendage where blood doesn't go in it, and that will stop you from having a stroke because the blood doesn't pool anymore. However, they only recommend that if you're already going to have open heart surgery for something else, like a valve problem or something like that, because it's a little bit extreme to go in and put a device inside your heart where you could just take a medicine and slow your rate and stuff like that.
And for those, for instance, Karima asked this question, but I'm sure for those who have been diagnosed with AFib, should it be a cardiologist that's treating them, or do you feel comfortable with primary care physician paying close attention, can treat and maintain and manage atrial fibrillation?
Primary doctors can definitely treat atrial fibrillation. The time to go to a cardiologist is if it's unstable, if it's not responding to treatment, if the rate is unstable, or if there are other heart problems that are causing the atrial fibrillation, such as coronary artery disease or a valve problem. That probably means you need to go to the cardiologist for those other reasons, and then they would take care of your atrial fibrillation as well. Used to, we would admit every person that had atrial fibrillation to the hospital, and we would anticoagulate them with Lovenox, and then we would bridge their therapy to Coumadin. But it's not something that you have to get admitted to the hospital anymore. With the newer anticoagulants, you can start those and start the rate control, and you don't really have to be in the hospital for that. And the one that went to the ER and they had paroxysmal AFib, they should definitely be seeing a primary doctor about that. But not necessarily a cardiologist unless it's unstable.
Well, excellent. Well, thank you so much, Dr. Rayner.
Yes, sir.
Thanks for taking the time with us today. I'm going to turn you loose to go treat some of these types of patients. And so thank you again, and I look forward to being on the show again.
Thank you.
Thank you guys for being patient with us while we were sharing the screen. So great questions today. I think we covered most of the basis of the questions that had come in already. You can continue to ask questions. The one thing we wanted to transition to is to again talk some. We've updated you about once a month, maybe a little bit more often, on the success we're having in opening primary care clinics in Lower Alabama, the Gulf Coast. So for those of you maybe from other parts of the world or around the country, Alabama, if you look at the bottom of the Gulf Coast of Alabama, it's split by a bay, Mobile Bay. Mobile is on the west side. Baldwin County, Alabama is on the east side. For those from the Midwest and the South, a lot of tourists travel to the Gulf Coast. They call it the Emerald Coast of Alabama and Florida. And that's the area in which we've opened these new primary care clinics, trying to deliver prevention medicine and quality primary care to patients in this market. We are looking to expand rapidly into North Alabama, Tennessee, Kentucky, other markets where we're looking for markets where there is a shortage of primary care physicians, where there's a growing population of patients who would be Medicare eligible, and where we can find the team and recruit the team of people who are willing to adopt the way that medicine should be practiced. If you look at our website, do a little bit of a sales pitch. If you look at our website, we had a great review yesterday, for instance, from a patient that came in. And this particular patient on Facebook had commented on how drastically different the experience was. And that's what I wanted to talk about some, to explain this channel that we've done for years is a channel that was born a few years ago when Ford and I were working in Pensacola, Florida, building out clinics, doing something very similar there. And kind of his semi-retirement interest in starting the channel and doing it. And we decided to move over into Alabama and began opening these types of clinics as well. And when we say these types of clinics, they reverse the paradigm of how you normally visit a clinic. And I'm a business guy at heart, although I've been involved in clinical companies, but from the management leadership role. But we don't say we can put a man on the moon, but we can't schedule an appointment for a patient that when they show up, we can actually see them when they show up. So healthcare is actually approach the patient with, in my opinion, with a mentality that says, this is physician-centric, this is, and I know I have a lot of physicians that are listening to this, and you can challenge me on it, but I think I'm right. It's physician-centric and it's staff-centric. You make appointments to fit us, and you come in and wait for us to do our thing. And you may wait 30 minutes, and then we move you into a room. And so we wanted to reinvent the way in which the experience for a patient would occur, where it was patient-centric. So, for instance, in our clinics, we don't have waiting. We know you're coming in. If we scheduled you on the appointment scheduler for 10 a.m., why am I surprised you come in at 10 a.m.? Why would I book 4 people at 10 a.m.? If I were a car salesman and someone wanted to come in and buy a car from me, I wouldn't book 3 people at 10 a.m. and just say, well, you just wait out there in the car lot for 30 minutes in the heat, or sit here and wait for 30 minutes in an uncomfortable chair with a bunch of other sick people while I take care of this customer, and that customer, and then I'll get to you when I can. That paradigm is just broken. So we're reinventing the paradigm and investing more into the time element of the patient with the provider. And we're going to try to, kind of change this. Fortunately, Medicare has recognized the need to make some of these changes and has changed the way the compensation works through programs such as Medicare Advantage plans. There's a lot of confusion out there about Medicare Advantage plans. And I know sometimes our own readers have made negative comments, which is fine. You may have had a bad experience with a Medicare Advantage plan. However, the purpose of what they're trying to accomplish is to address this disparity in healthcare and to create what we describe as a fee-for-value arrangement, where they work with the provider in the clinic and compensate them more on how well the patients do than on how many patients they see. When you hear fee-for-service healthcare, that is the nomenclature of I get paid as a clinic based on however many services and the complication of those services are for the patient. A fee-for-value clinic says, wait a minute, shouldn't I be rewarded as a clinic and a provider for keeping you healthy, not for treating more and more complications? So we make almost a perverse incentive in healthcare, and we see the abuse in a lot of places, horrible abuses of, let me find out what all I can do to you and for you, and then bill for it and be compensated based on the number of things that I did and how many times I get you in, and not on an end result at the end of this year. If I kept you healthy, if as a clinic, if we helped you address problems, then be compensated based on the success. So that's what we're doing. Our update's been going very well. We have 5 physicians so far in 4 different clinics operating either currently or will be operating by January the 2nd, 3rd. And we're going through a lot of training with staff, training and changing how we interact. So the actual encounter is about an hour, complete hour with the patient. Some of that's with a nurse practitioner, some of it's with the staff, some of it's by phone, and 30 minutes or more of it is actually with someone like Dr. Rayner. We call it hands-on, where he's examining you, talking to you, drilling deeper into what your conditions are. So that's currently what's going on with Alabama. Enterprise, someone says they have family in Enterprise, Alabama. We actually had Enterprise about an hour and a half away from the nearest clinic to Enterprise would be Spanish Fort. But believe it or not, we actually are having people drive an hour in. It is so difficult to get appointments. So many retirement people have moved in that there were only 1 clinic that we found in this entire county of 250,000 people who were taking new patients who were Medicare aged. So we're opening up multiple clinics and taking these new patients in. Bill Late says, open your next clinic in the Brentwood, Franklin area. Bill, I'm from Franklin, Tennessee. I would love nothing more than to be able to stay home. So that Tennessee is on our radar. Franklin, Brentwood doesn't have the same kind of shortage that some other markets do, but as an old Williamson County boy, I'd love to be closer to home more often, but my kids live there and I'd love to see them more. But we are looking at Tennessee as being some of the next market that we penetrate, as well as Kentucky. Someone says need a clinic in Hardin County, Kentucky. I will be actually in Kentucky on Monday meeting with clinics in Kentucky, and then I have to make it to North Alabama to interview a clinic. We're looking at some clinics that already exist and maybe acquiring those clinics and retraining them and repositioning them from a business perspective. While Dr. Brewer works with the clinics on how to adjust clinically, I'll work with the staff and with the team I have, and how do you rebuild, how do you reinvent and reimagine yourself and reinvent the culture of healthcare. That's as much as anything what we're trying to do. Yes, Martha Wright, my Aunt Martha did come. She does have family down here. I have a first cousin that lives not too far from here. In fact, I actually have 2 first cousins, one being her son and the other being another first cousin I have that live in the proximity. So her and her husband did come, go to our clinic. We're in the clinic I'm sitting in right now. So we will, if you're Medicare eligible, if you have Medicare, if you have any of the Advantage plans, we'll take you as a patient. And so our goal is to get you as healthy as possible, as quick as possible. All right, I think we have covered most of the questions. I do recognize that PS asked a question about longstanding persistent AFib. I'll ask if you can re-ask that question maybe next week when Dr. Brewer's on, since our clinical provider has just, Elvis has left the building, as we'd say, so I wouldn't want to answer that. The rest of them, I think have all, we've answered most of those questions, addressed them. So we are allowed to cut short a little bit every once in a while, but I want to express my appreciation. Thanks for listening to the channel, for participating with us, for sharing it. a lot of what we're trying to do with this channel, we will create the content. And as you probably see and know, our team of guys, Gilbert and others behind the scenes, there's a whole team of people who do a great job of then taking this content, one, making it work well with the talent that they don't have from us. But then they take that, put it on YouTube, put it on Facebook, create shorter videos, edit it, and make this content more available. We usually have several thousand viewers within 24 to 48 hours of these videos being created. So a lot of your questions are important. If you go back and look at YouTube, you'll see we ask and answer the question and then cut that question out and then make a short about it. So you participating helps us a great deal because that tells us, what our listeners are interested in. We also will take emails. You can go to our site, either the Jubilee site or the PrevMed site. And if you want topics, email us what you think those topics would be, and we'll address them. We'll put it together and address those topics. So thank you, guys. Thank you very much for listening again today. Thank you for participating. And until we talk again, take care of your health. Do the best you can to stay and live on this place as long. We only get one trip around, so make the most of it. God bless, and we'll talk to you on the next show.